So we have for our first session, a discussion on being pragmatic in the time of COVID-19, linking a cancer diagnosis with treatment. So if I may introduce our chair for this session, we have with us very fortunately to have Dr. Mazanah Muhamad, who is chairing the first session for this morning, who is president of the KanWork Cancer Society. She is based in University Putra, Malaysia. KanWork is a non-governmental organization aimed at helping cancer patients through informational, emotional, and spiritual support. Set up in 2005, well, so that's like, what, 16 years already. KanWork provides cancer awareness programs and support systems for people associated with cancer. So without further ado, I hand it over to Dr. Mazanah to introduce her two speakers and to start the session. Go ahead, Dr. Mazanah.
Thank you, Azrul. Assalamualaikum warahmatullahi and good morning. As we know that early diagnosis with timely and effective treatment is crucial in cancer management. And this becomes more challenging with the pandemic. So this session will deliberate on this issue, what works and what can be better. So with us this morning, we are very fortunate to have two distinguished speakers, Dr. Arunah Chandran, who is a public health physician at MOH, a senior assistant director in the disease control division, and her roles includes policy and problem development and strategic implementation for the interventions for NCD, including cancer, Dr. Arunah. And the other speaker is Ms. Maheswari Jaganathan, a breast cancer patient navigation program at Cancer Research Malaysia manager, and she was an Acumen of Malaysian Fellow 2020. Without further ado, I welcome Dr. Arunah to on the floor.
Thank you, Dr. Mazanah, for the kind introduction. It's a pleasure to be here. It's a pleasure to be invited to be sharing some of my perspectives today. Allow me to share my screen. Dr. Mazanah, can I confirm if you can see my screen over here?
Yeah, I can see yours better.
Okay.
Good. Well and good.
Okay, great. All right, great. So once again, thank you very much for giving me this opportunity. My name is Arunah. Like Dr. Mazanah introduced, I am a public health physician at the NCD section. So when I was asked to speak a little bit about how and what are the pragmatic solutions in terms of linking diagnosis to cancer care, I thought it would be just appropriate for us to speak about Malaysia, at least from the MOH perspective, on how we navigated cancer screening in the COVID-19 pandemic and what are the opportunities that we've learned during this period in order for us to build back better. So with that, we all know that there has been downstream effect of the pandemic in terms of global cancer prevention as well as control, and the effects have been basically wide-ranging, including in Malaysia. So in May 2020, WHO went and did sort of a rapid review and found that in 75% of the countries reported major disruption of NCD services. Now, this includes cancer, and some of the cited disruptions were either staff redeployments or cancellations of population-based screenings, cancellations of inpatient elective care, and also poor access to facilities. Now, other than this rapid review, there were also other sort of multinational studies that found that, for example, 13 out of 17 low middle income studies had suspended cancer screening activities for more than 30 days. And more than 9 countries reported suspension of diagnostic services for that similar duration. And if some of us are familiar with the cervical cancer elimination strategy, we call it the 90-70-90 cervical cancer elimination strategy. We know that the first 90 refers to basically HPV vaccination. And even for that, up to 60% of countries in the Southeast Asian and Western Pacific region reported disruption in terms of HPV vaccine delivery. So we know globally there has been basically a major downstream effect of the pandemic and global cancer prevention and control, and Malaysia is not an exception. Now, for the purpose of my presentation, I'd like to use colorectal cancer screening as a use case, basically to demonstrate our experience from the MOH perspective and to build a case on what are the opportunities that exist as we move forward. Well, I chose colorectal cancer for personal reasons. I used to manage the National Colorectal Cancer Screening Program, and also the fact that it is the most common cancer among men in Malaysia and the second most common cancer among women. On the right side of my slide, you would see I've actually put a dollar sign. I'll come back to this a little later. The effect on cancer are like obviously wide-ranging, social, emotional, mental well-being. But the reason I've put the dollar sign there is the fact that a lot of times that is not something that is often spoken enough. Malaysia, the Ministry of Health has actually gone and done 2 big surveys and 2 big studies to look at what are the costs of NCDs, including cancer and their risk factors, on both Malaysia's GDP, basically looking at indirect costs and also direct costs of direct healthcare costs of NCDs and cancer. The first part is actually published and available and online. And if you look at just due to absenteeism, presenteeism, and deaths alone, cancer itself is estimated to cost Malaysia up to 1.8 billion in losses. And this does not include the direct healthcare costs. Now, with that, I'd like to bring everyone to the colorectal cancer screening program that I was speaking about. Now, Malaysia began the National Colorectal Cancer Screening Program back in 2014. We used primary care clinics as our entry point, and we used the I4BT, or we call it the immunochemical fecal occult blood test, as a screening kit. Even before the pandemic, there were already multiple challenges in the colorectal cancer screening program, right? Firstly, we were only screening less than 1% of our eligible population of 50 to 75 years. And even with those who we had eventually screened and tested positive, for example, one of the major deterring factors for the gold standard colonoscopy attendance was the fact that people had logistical challenges, there were social influences, they were afraid of the procedures and other competing priorities. Now, with COVID-19, we know that there was severe disruption in terms of NCD prevention and control delivery. And this slide basically shows how there was a severe reduction in outpatient attendances in our primary care clinics, not just outpatient attendance, there were also other services affected, but I'm just, for the purpose of today's presentation, I'm showing this because this then shows us that even due to our outpatient attendance and due to the fact that our colorectal cancer screening program basically depends, it's an opportunistic program. Basically, it means that we offer you these services if you were to attend our healthcare facilities. When there's a drop in healthcare facility attendances, it sort of leads to a drop in screening activities as well. So based on the routine indicators that we collected in 2019 and 2020, we know that, for example, in 2019, there was about 31,000 eligible candidates who we screened. And in 2020, there were about 42,000 that we screened. Despite the initial drop, we see a nice sort of like drop there in early 2020. And this obviously coincides with the announcement of Malaysia's MCO. We managed to sort of pick up, we managed to sort of increase the number of screenings towards the end of 2020. And this could basically be attributed to the fact that we had procured higher number of kits, and it was also in line with the fact that we were at that time planning to progressively expand the screening coverage. We had also thought that we needed to issue basically an interim guideline to all primary care clinics, encouraging basically our healthcare providers to continue providing opportunistic screenings in areas that were green zone where COVID-19 cases were low. So which is why you see a sort of an increase towards the end of 2020. Now, despite that, I had already earlier mentioned that there were already deterring factors coupled with the challenges during the pandemic has led to, if you look at colonoscopy attendances rate, it was only about half, 50% in 2019. And in 2020, that number went even lower. So poor colonoscopy attendances continued and it got worse during the pandemic. We also know that with anecdotal evidences that COVID-19 has disrupted treatment and follow-up. Now, with all that being said, right, how do we build back better? Do pragmatic solutions exist? And the white paper that Azrul was talking about really sort of summarizes everything that can and possibly be done. What I'll be presenting here is a perspective, from a public health perspective, at least from a health systems point of view, on what are the things that we could be focused on, what are the things that we have learned during the pandemic, and my perspective to what could possibly work. So bear with me. So we know there are low-cost interventions. We know there are WHO best buys, there are international evidences to reduce the burden of cancer itself. But we know that effective, basically cancer control programs require that initial investment, right? In the long term, it may be cost effective, but the initial cost investment has to be there. And that requires strong political will. Now, we've seen that political will for COVID-19. Overnight, there was a whole of government, there was a whole of society response in solving what was a public health crisis, simply because it was seen as not just a threat to lives, but also livelihoods. Basically, the dollar sign that I was talking about earlier. So for example, COVID-19, right? It was declared a public health emergency and it became a notifiable disease almost overnight by law. And we used an emergency ordinance for COVID-19 that enabled governments to actually take over assets for pandemic response. And in contrast, in many low and middle income countries, including Malaysia, cancer notification is yet to be mandated by law. So this is what I mean by political will. You can have strong governance, you can have everything well done on paper, but with that political will we saw for COVID, that notifiable disease by law is something that's doable, and that I feel is also possible for cancer. Now, future preparedness strategy is my next point, right? We know that when COVID, the pandemic hit, we were all scrambling to ensure that NCD services continued in a manner that is with minimal disruption, but we were scrambling. And in order to avoid that, I feel that future preparedness strategies must consider NCDs as basically an essential foundation for human security. I know this may sound like a very big thing, but we need to start thinking in terms of a crisis. How do we then ensure not just clinical management, not just rehab, not just everything else that's in the tail end of cancer, but also how do we then focus on ensuring the full continuum of cancer care, prevention and early detection also continues. Now, that's preparedness strategies. Now, moving on to financing. We know that the pandemic has basically diverted precious resources from cancer control. How do we now press governments and international funding to explore any avenues to mitigate this impact? We need to firstly address the underinvestment in cancers. And I think the most important part at this point that we can do is to basically demonstrate the economic consequences of cancer care, not just to the individual, not just to their families, not to the community, but also to the country, and illustrate the benefits of investing in cancers. And I know some colleagues in the academia are working on this. At MOH, we're trying to do the same, to basically demonstrate in dollars and cents how important it is to invest in cancer. Now, it's also simultaneously important for us to build sustainable partnerships. And again, I'll go back to how COVID-19 has catalyzed large-scale collaborations to assess impact, foster management, and also improve outcomes for COVID-19 in a very rapid manner. So this highlights there's actually interest from communities basically outside of health in times of crisis that can, I believe, be sustained for cancer control programs. So this is something like to look at things on a bigger picture. What I've really spoken about, if you see in my slide, is on everything that's on the left side. But what about the low-hanging fruits, right? So on the right side, I feel something is that can be done in a short, medium-term time frame, innovative digital solutions. Now, we can implement alternative and new care pathway for cancer. I think this is very important. Again, going back to COVID, we know that the use of digital platforms can basically safely and effectively be implemented when access to face-to-face care becomes challenging. And in Malaysia, previously an almost absent regulatory environment hindered the previous efforts of digital health intervention. Now, during the pandemic, a simple sort of a guideline, an interim guideline, a special advisory, MMC sort of stepped up and issued this special advisory for professions where this special advisory sort of accelerated efforts for teleconsultations, for example. Doctors and healthcare providers were able to provide the service in a confident manner because of this interim guidelines. So in order for us to sort of build back better, I think it's very important that we leverage on digital solutions, but at the same time, the onus is on us to improve the existing infrastructure, the regulations, legislations, the standards, and the interoperability between the existing systems. I think the most important thing that we've sort of learned is we need to start moving away from the sort of standalone sort of solutions that we have been providing. I'll digress a little bit from cancer. I manage one of the largest diabetes registries in the world. Yes, the information in the registry sort of provides us the information that can be once again looped back into improving NCD care, but it is a very resource intensive sort of registry where it's a primary data entry. It requires a lot of resource, effort, and time. And to duplicate and replicate this effort for diabetes to every other disease is something that's almost impossible. So when we think about digital solutions, when we think about monitoring, we think about registries, we need to start thinking about how they can align with not just national, but also regional digital strategies. And the other thing that I think we always think about is when digital solutions are implemented, they cannot just focus on those Apple users who are already probably familiar with digital solutions. We need to think about implementing things without further exacerbating, I think, the digital divide, taking into account the needs of the underserved and vulnerable. When we build back better, we should think about not leaving anyone basically behind. So I think that's very important when we speak about digital solutions. The other thing that I think is quite important is decentralizing our prevention and early detection programs. Now, in Malaysia, traditionally, our sort of screening programs have been based in health facilities, implemented by healthcare workers. Now, we saw that in terms of crisis, there were major disruptions because we wanted to decongest, because our healthcare workers were mobilized. So moving forward, how do we then take this out of healthcare facilities? How do we then move this sort of screening activities and early detection activities into the program is something that can be done, quite pragmatic, has been done elsewhere, learnings that we can sort of take and implement in Malaysia. And the other thing I think is quite important is it's about time we moved away from opportunistic screening, to speaking about less than 1% of our eligible population, at least for colorectal cancer screening program, and start making this into an organized population-based screenings. I think the efforts are actually underway. There are small pilots that are looking to implement this, and we look forward to those findings and to those learnings and how at MOH we can then now scale this. While speaking about population-based screening, I think the other thing that we must think about is thinking about how we're going to build capacity. I think that's quite important as well. And I think I'd probably like to end by saying that I know when I spoke about decentralizing prevention and screening efforts, one of the components is probably patient navigation. But in my slide here, I gave patient navigation a box of its own because I feel that's how important I feel it is. Like I said earlier, even before COVID-19, barriers in access stood in the way of patients at achieving optimal cancer care. And I believe that a good patient navigation program that seeks to address these structural and also the systemic barriers are basically in the most optimal position to address these issues post-pandemic as we move on, or what we call it, into an endemic world. And we know that from high-income countries, there is emerging evidence that if patient navigation is done virtually, there is even a potential sort of success that can be seen. So when we speak about doing everything, doing all of these, I think it's also quite important that we, as we do, we document, we monitor and evaluate, and we improve. And at the same time, I think just before this, I mentioned capacity building. As we run programs, it's so important for us to build capacity, at least from our point of view. I think if there's one learning from the pandemic, it's taught us that monitoring of continuity of essential services is so vital, especially for cancer. A robust monitoring mechanism will ensure that policymakers and program managers can identify the changes in service utilization and re-strategize at times when it's necessary. So I'm going to stop at that, and I'll take any Q&A, I think, after Mahesh presents. And I think I'm looking forward to hearing about her experiences in terms of the patient navigation itself, because I believe in terms of the low-hanging fruits, one of the things that we really need to focus on. Thank you so much, Dr. Mazanah. I'm going to pass it over to you.
Thank you, Dr. Arunah. Gentle reminder to all, you are welcome to post your questions on the Q&A box, which will be looked into at the end of Ms. Maheswari presentation. So we welcome Ms. Maheswari now. Oh.
Hi, good morning, everybody. I'm Mahes, and I'm from Cancer Research Malaysia. I'm attached as the Breast Cancer Patient Navigation Program Manager and work closely with Ministry of Health to establish the patient navigation program for breast cancer patients. And it's a great opportunity for me to be able to share my experience over the challenges that was faced by breast cancer patients during pandemic. So if you see, the cancer survival among breast cancer patients in Malaysia is improving, but it is highly among high-income women. And if you look at low-income women, mostly are presenting late, and most of their second opinions are from the alternative practitioners, and they access to public healthcare services. And therefore, their survivals are lower from the high-income women. And if you see in Malaysia, our 5-year survivorship is 67%. 43% of patients still arrive late with late-stage presentation, and they have limited access to treatment, and some will default while they are going through treatment itself. And this is mainly associated with 4 major barriers to cancer care. First is the knowledge, followed by financial, transportation, and also emotional support. Together with Ministry of Health, Cancer Research Malaysia have established the Malaysian model breast cancer patient navigation. They have 3 phases in it. First phase focuses on hospital-based navigation, followed by phase 2, affiliation with primary care clinics, and phase 3 is intervention at community area. And by completing all these phases at one selected area or district or even states, you will be able not only to damage control intervention, but also detect more people to come in at early stage, and therefore it can actually downstage breast cancer burden in Malaysia. And in 2015, when we set up the first demonstration model in Hospital Tengku Ampuan Rahimah, and we published our first paper in Journal of Global Oncology about patient navigation program, and we wanted to set up and replicate those models to 3 other state hospitals. And the launch happened in end of November 2019, and all local members and partners were all pumped up to start the first operation in all 3 hospitals in Seremban, Kuching, and also Sabah. But that's when we get the news that the government has actually announced the MCO, and we all will be going into movement control orders from 18 March. And at this time, it was also a lot of people from workforce were shifting to work from home transformation. And for patient navigation, primarily our work mainly involves face-to-face communication with patients at the navigation center, clinics, ward, oncology daycare, and also home visit. And we had to move very fast, pivot our operation, and work together with the Ministry of Health team to identify approaches or intervention that we can actually use to help patients cope better during the pandemic. And in early April to June 2020, we went and we conducted a telephone survey to understand how we can actually support breast cancer patients during pandemic. And it was completed by 211 breast cancer patients who responded to our survey. We found 25% of breast cancer were already in crisis during COVID-19 pandemic. And for low-income household, especially the one who's earning less than 900 per month, up to 35% of patients were already in crisis. And they reported high emotional impact. And this is due to fear of infection and treatment disruption for people who are already in active treatment, followed by financial impact where patients reported they have difficulty in paying their bills and also utilities and also rental. And they're also unable to pay for treatment because those money has to be now prioritized which one to be used either for treatment or shall I use that to put food on the table. And third one was based on family. Many patients were separated from their family members, especially their children who can be their caregivers or even the spouses due to work. And they also had disruption of daily activities because of the movement control orders. And from the survey that we conducted, we found that there is 3 patient group that requires targeted support to access to life-saving services during pandemic. The first one is patient who's demonstrating low literacy and poor health. Second was patient from low-income household. And third one was patient with metastatic diseases. And right after the survey, the team from Cancer Research Malaysia, we moved to remote navigation to help and support our navigation team in MOH to run their clinic run their operation in the clinic while we support them from home. So most of the patients were given information card to access to the hotlines for each navigation center and also specific to their navigators in charge at the site. Most of information are being tracked through WhatsApp, and also all coordination for patient surgery, chemotherapy, radiotherapy is all being done through phone calls and WhatsApp calls. And there was also shifting of patients sometimes to district hospitals for surgery as well. And when it comes to low-income household, of course, there was many of them received some of a food basket, but that was not enough for cancer patients who was actually recovering from surgery or recovering from chemotherapy. We have to top them up with vegetables and also proteins. This we work directly with patients. You can see a picture on your left showing this auntie was showing us that she has left nothing in her fridge except for cold waters only. So we work directly with patients who can actually have the resources to go and buy with the fund that we can transfer. And we selected some of our local community partners who have taken the responsibility to continuously help patients while they can be independent. They can be independent on their financial status. And when it comes to patient who was affected by metastatic breast cancer, some of the patients were very fortunate that they were under the area of coverage for palliative and end-of-life services, but they were still patient who was not getting those services for. So these are the patients that we can actually assess for medical equipment need. At least they have a proper place to sleep, and they can, whoever bed bound, they have comfort in staying at home and being supported during the bed by the family members for bed care and home care. And it was really surprised to know that patients were also asking for pre-loved clothes because they didn't have any decent clothes to wear to come to hospital because they don't have the money and they cannot go out to buy anywhere of their clothes. And for some of the severe cases who were actually stranded at home with young children, older parents, we had patients who actually faced severe side effect of post-chemotherapy, or people who had metastatic breast cancer who were suffering from severe pain, bleeding from fungating wound, and their family members or their neighbors had they unable to help them because they were all had fears of infection, and they were hesitant to send the patient on their own to the hospital because nobody can actually accompany them in the hospital. So we had to go down to the house, explain to them, make sure the children or the people at home, that somebody is going to take care of them while the mother or daughter being admitted in the hospital. And we found that community partnering really helped us very much during the pandemic. They were really brilliant at helping us and take up some of the responsibility at the local community. So they continue to support them by sending food item, electrical equipment, send them milk, diapers, dressing sets. We also work with Saindabi Yayasan to send almost 300 individual hygiene pack for newly diagnosed breast cancer patients in both our navigation centers in Klang and also Negeri Sembilan. We also work with JKSP in hospital in IKN to ensure patient who's traveling for radiotherapy are given placement at the halfway home in Makna. And also these awesome, brilliant ladies who are the Grab drivers who actually helped many women who are traveling on their own to ensure that they don't get disruption or get interrupted while they're going for their radiotherapy. From here, the main lesson that we learned through the 19 months of running the operation during pandemic, we think that it makes much more sense now than ever to have patient education program for cancer patients. And we have started that with breast cancer, and we hope that we will reach more cancer patients. The first one, the big picture principle that we want to adapt not only during pandemic, but also post-pandemic, the adaptability and agility to change, and also focus on what you can actually do during pandemic and don't get distracted over what you cannot do. And how much is it important to invest on time and build the connectivity with community, local community, who can actually take up the burden, so we, the operation team, can actually focus on new breast cancer patient that is coming to the center. And the third one is leveraging on digital and technology has helped us not only to ensure that we collect all the data and all the challenges that patient has actually reported, but also teach patient to keep the communication going on with us, so that they always know that we actually we are there at the back and we are reachable by just one call away. A lot of women do find it very difficult, but in 1 to 2 months, everybody managed to adapt to this. And we found like even patients who are unable to text us, able to sound voice messages and everything. So it helped us to go on to help patient in a way that we actually can. And this wouldn't be, it wouldn't be possible without our main funder, Saindabi LPGA Malaysia, and also our working partners at Ministry of Health and all our 4 navigation centers. Despite many challenges and resource constraint, in 2020, we managed to navigate 751 newly diagnosed breast cancer patients in 2020. And with this, I would like to end with my video.
Fear, poverty, and illiteracy are preventing low-income breast cancer patients from accessing life-saving treatment. Despite the best efforts of many institutions, low-income cancer patients are nearly 2 times more likely to die of breast cancer. Each year, 1,200 Malaysian women die of breast cancer because of delayed diagnosis and limited access to treatment. The numbers are rising as Malaysia struggles with a growing number of breast cancer cases and rising cost of treatment amidst post-pandemic socio-economic issues. With an average age of just 50, these are women who are dying at the prime of their lives, mothers, daughters, and sisters in our families, leaving family members in a state of hopelessness. So what should we do about it? Patient Navigation is a patient-centered program designed to give low-income women the hope of surviving breast cancer. Our navigators work closely with the Ministry of Health and many social welfare organizations to guide, assist, and support patients in overcoming challenges. The process of patient navigation includes providing emotional support to overcome fear, helping patients understanding complex medical terms to make treatment decisions, finding financial aid to pay for treatment, helping patients recover at home. Cancer Research Malaysia believes no cancer patient should ever battle cancer alone. We operate 5 days a week. Our one-stop pink ribbon centers, PRC, are safe havens for patients. Navigators first help patients come to terms with their diagnosis, building trust and an effective partnership. By being sincere, compassionate and empathetic, we assure patients that we will always be with them, strengthening their faith in going through treatment in a way that they might struggle to visualize. PRC currently operates in 4 states, in Klang, Seremban, Kuching and Kota Kinabalu. So what happens next? Breast cancer patients who struggle to understand medical terms and are afraid will be guided through so that they can have the best possible care. Our navigators at the hospital team are there to facilitate the entire process. We provide information to equip patients with the right knowledge to make decisions about their treatment and work with them through any side effects. But we don't stop there. We also assess the patient's other needs and their financial limitations. We provide counseling for social problems and match patients to agencies and charities who can help. And when patients are ready to go home, we equip patients and their carers to cope with their changing needs. So what can you do to help with your support? Cancer Research Malaysia relies entirely on donations to ensure that lives are not lost to breast cancer because of fear, poverty and illiteracy. Every awareness and collaboration created, every donation received will bring us closer to closing the gap in survival for breast cancer patients. It is up to all of us in Malaysia to ensure that low-income breast cancer patients know that every woman matters, every life counts. Our breast cancer patients need your help because every cancer patient deserves an equal right to be a survivor.
Yeah, with this, I thank everyone for listening, and I would like to pass to Dr. Mazanah back.
Thank you, Ms. Maheswari. So we are now open to Q&A session. You may post your questions in the chat box. And we already have one question on hand. That is, I'll read the question. You have 3 minutes with YBKJ. What will you pitch for a pragmatic solution to improve cancer screening in Malaysia? For you, Dr. Arunah.
Thank you. And I think I've already, it's an interesting question and it comes from actually my boss. So I think I've already spoken about this in my slide earlier, but if I had 3 minutes, I think I would go for the low-hanging fruit. I spoke about the sort of the systemic changes to the healthcare systems that would then improve a lot of things, but without going into in-depth of all that. I know governance, financing, leadership, partnership are big words, but if I could pitch a 3-minute one, I think I would go to scaling patient navigation. We know from Mahesh's presentation that it works and it's important. And the other low-hanging fruit would, I think, be perhaps mandatory cancer notification. It's something that can easily be done in this current climate. That doesn't require excessive financing, but when we think about mandatory cancer notification, we must also make it feasible and make it easy for healthcare providers to make that notification. If we are going to set up a complicated system that would require for them to navigate, it would take time for them to even do that notification. Yes, it becomes a little bit more difficult. Perhaps the one way is to think about how we can make those notifications in an easier manner for healthcare providers, not just mandated by law. So these 2 things, navigation and I think, and I think, I'll stop at that. I think there's several other questions.
Okay,
well.
Thank you, Dr. Arunah. Sorry, we have another one for you. Hang it back.
Okay.
This is question from Ms. Boon Liu Siu. So, is MOH having a systematic national cancer patient registry? Usually, we only get to see published statistics that are rather old, like a few years before, and not currently.
I agree, and I think this is something that has been sort of brought up, in previous discussions. I think the current process that the notification, the cleaning of the data, and the reporting takes time because of the way that we had sort of set up the whole registry. And I think one of the previous solutions that have been actually suggested is for us to perhaps publish interim data that is available before we can go through the whole cleaning process. And I think that would definitely help. But I think it's more of a systemic issue because of the way we've set up the registry, rather than blaming the registry itself for having a delay in the process. So I think it's something that can be done, and I think it's something that we're currently working on. I have not personally worked with the cancer patient registry before, but having worked with other NCD registries, I can tell you that there are certain processes that can definitely be sort of shortened, and while we wait for verified published results, we can definitely sort of work on releasing interim information to the general public and then work on verifying those. I hope I answered that.
Okay, thank you.
Yep.
Thank you, Doctor. Another question from Dr. Faisal, but this time for Ms. Mahes.
Okay.
What would you say are the key pain points to upscale and expand patient navigation based on your experience?
Yeah, thank you for the question, Mr. Faisal. I think at the earliest stage, the main reason patient navigation took time to start as a demonstration model is we didn't have any model that was established in Asia that we can actually look at it. And for us to convince a lot of people to take up this program without any success or any model, it was very hard. So it was buy-in from our key collaborators, or also work collaborators, and especially for us as an NGO who's also based on cancer research, the buy-in and especially the champions in Ministry of Health. And it was really good that we actually found the match. And when we actually was given the opportunity to establish the demonstration model in Hospital Tengku Ampuan Rahimah, I think that gives everybody clear evidence that it works. And in just like 1 year, we managed to get more people to come in to replicate this navigation program in their own hospitals. But of course, the pain point is also funding. So currently we are basically based on public donation, and this is a huge thing that we continuously fundraise to ensure that we support Ministry of Health hospital to support these low-income women who are actually presenting late and actually dying of cancer, that we can actually improve, that they can be put into the survivor box than mortality box. I hope I answered the question, Mr. Faisal.
Okay, thank you, Ms. Mahes. Hanging there. Another one for you. This time from Mr. Tampu. Are there plans to extend T-Vision centers in other states in Malaysia? Is it in the pipeline?
Yeah, thank you, Ms. Tampu, for the question. Yes, it is in the pipeline, but we're going to approach a different approach to start the expansion. But most probably we are in the plan and in discussion to start an eco model, so that when we start the model or the program in any Ministry of Health hospital, these are sustainable by the team itself in the Ministry of Health. So we can actually do an implementation and able to give them back so they can actually do this. So yes, we do have that in pipeline. But currently for the 2 years when we were hit hard on pandemic, we just managed to sustain and make sure the current operation in all the 4 sites are being optimized. Yes.
Okay, thank you. This is another one from Ms. Bilyu, that is interesting. MH invested 70 million to set up MySejahtera app to tackle COVID-19 database and tracking. So is there an opportunity to exploit and expand it for cancer?
Yes, definitely. So that would definitely be a yes. Currently, MOH is also looking into how we expand MySejahtera itself because of the large uptake of in the population to tackle not just cancer, but also NCD as a whole, starting from not just service provision, but also looking into research, how we can then start doing population-based screening through, for example, MySejahtera, instead of waiting for for a 4 years, sort of every 4 years population-based screening that population-based NCD studies that we're currently doing. So yes, the question is, we're definitely looking into how to utilize the current MySejahtera app to expand that beyond COVID-19. And I think there was an earlier question to me as well in terms of budget for breast and colorectal cancer screening, but the take-up rates are very slow. Dr. Mazanah, do you mind if I took that up as well as part of the answers, or do we have time?
Yeah. There's another one here that where the MOH has set aside significant amount of budget for breast and colorectal cancer screening, but the take-up rates are still very slow. So how should we encourage Malaysians to take up this support?
So we know from our experiences in terms of health literacy levels among Malaysians, not just for cancer, overall NCDs is rather low. However, I think it's also, MOH has a big part to play in terms where I can speak definitely for colorectal cancer screening. It's been an opportunistic screening that has been provided at MOH healthcare facilities. So which means if you were to attend MOH healthcare facilities, we would then ask you if you had done those screening, and the budget allocation and the program, in a way, the program was sort of funded is it is not enough to create the change, I believe. So that's why I said in terms of moving, we need to start moving away from opportunistic screening to perhaps how we can do population-based screening. Dr. Mazanah, I'll give you an example. We are now advocating for COVID-19 self-test before we balik kampung, correct? We now have sufficient evidence from program ROSE, for example, on how self-sampling and HPV testing in Malaysia is something that is feasible, something that's doable. MOH during the COVID-19 pandemic has also tried to work on self-test using IFOBT kits in the community itself without having to attend a healthcare facilities. So I think moving forward, those are our strategies that we need to start thinking about instead of thinking about healthcare-based facilities for screening. If we're expecting people to come to our healthcare facilities and do this screening, it's Malaysians, especially with those we know with the poor literacy rate, the uptake is never going to go up. We need to start moving away from healthcare facilities into the community and make it easier for people to take up the screening. I hope that answers the question.
Okay, so we have another one for you. Okay, what do you think about our country preventive measures currently? So this the anonymous caller here missed your screening during the pandemic recently and was asked to come back a year later. And this is happening in public hospitals.
It is true. I do agree. I'm not saying in all public facilities, but I think in a way that, like I said earlier in my presentation, we did not, I think we weren't, and I think I'm probably allowed to say this out loud despite working for ministry, I don't think we were prepared for a crisis of this extent. We weren't prepared for this sort of disruptions in terms of not just for cancer, but NCD as overall. When it came to a time where COVID-19 was threatening both our lives and livelihood, we had to sort of mobilize staff. We had to mobilize resources to what was important at that point in time. So I agree there were definitely loopholes, and those are the loopholes that we need to think about as we plan our future preparedness strategies, putting NCD at the center of human security. And I agree that there were probably people who missed their screening. There were people who probably were delayed for follow-ups, were delayed for their screenings that could have probably resulted in them presenting at a later stage, especially for cancers. That is definitely something that we need to look forward as we move along. And in terms of the pragmatic solutions, I think I've spoken about it. It takes, I think it takes work, it takes political will, and I hope that we can sort of work in partnerships, not just rely on Ministry of Health to do this moving forward.
Okay, thank you. And I'm watching my clock, and I think our time is up. We had a wonderful session, that we have deliberate on being pragmatic in time of COVID-19, linking a cancer diagnosis with treatment. And we have been lucky to have Dr. Arunah and Ms. Maheswari with us. Thank you all. And for more, thank you all the participants who are in these sessions. I feel like this is alive with all the interesting questions. More are coming, but time is up. So thank you.
Thank you so much.
Thank you so
Thank
much.
you so much, Dr. Mazanah and Mahes.
And back
It's a lovely session.
Back to
care,
you.
bye.
Back to you, Azrul.
Thank you, Dr. Mazanah. Thank you to all the speakers, Maheswari and Dr. Arunah. If I could just ask you to turn your camera back on sekejap so that we can take a quick snapshot. Okay. I keep forgetting to do this all the time, so I'm blessed that I remember this time around. So if you could just give us a big smile and I'll take a snapshot. Okay. Thank you so much.
Let us know when it's over.
Thank you.
All right, great.
Frozen.
Thank you.
Thank
Bye.
you.
Take care.
Yeah. So thank you to all our previous speakers and for their remarkable discussions just now. I think we can all say that we have learned quite a bit, and I certainly saw quite a few points there that I would want to actually raise in future discussions. And one of the things that we can actually take away from is how do we not just look at problems, but now start looking at solutions. Is certainly building back better and wanting to make sure that we're able to make sure that nobody is left behind.